not really aware how many of the participants are pathologists here, but for the next 30 to 35 minutes that I have in my hand, I'll take you on a tour in the world of pathology where fungal diagnosis based on their morphological characteristics as well as their host tissue response, how a pathologist comes towards a diagnosis which helps in guiding treatment. So, yeah, just switch on the laser pointer. And I'll just put on a timer so that I do not really overshoot my time a lot. Now, for approach to fungal infections in histology, for a pathologist, it's just not the slide. We need to know, we need to have a robust idea about what the clinical presentation is. And in that, two of the things are most important. One is, what is the immune status of the host? Is the patient immunocompetent or immunocompromised? Because that gives an idea as to what the fungal pathogen will be. Will the fungal pathogen be virulent, of low virulence, or high virulence? Now think about an immunocompetent person. If he gets infected with fungus, then most likely it will be a primary pathogen like Histoplasma capsulatum, blastomyces, coccidioides, or paracoccidioides. But if the patient is immunocompromised because of anything like cancer chemotherapy or solid organ transplant or neutropenia or even diabetes, then low virulence pathogens, pathogens which are normal flora or just ubiquitous in the environment, they get an opportunity to infect as well as invade the host. And that is the bulk of fungal pathogens that we as pathologists see in the biopsy or surgical specimens. So that's enlisted here in this box. Now, the other thing is we also need to know whether the presentation is localized. As Dr. Dinesh Asati and Dr. Sagar Kadanga said, that if you see a disseminated involvement of the skin or involvement of the lungs or other organs, then you know it is a systemic presentation. So you immediately think that it might be a primary pathogen or it might be an opportunistic infection in a setting of immunocompromise. So that's very important to know whether it's a systemic or localized presentation, and endemicity. So in this part of the world, we hardly see blastomyces, coccidioides, or paracoccidioides, but we do see a lot of Histoplasma capsulatum, and I'll be talking about them in the the subsequent slides. Now, the next thing that helps a pathologist to come towards a clinical clue as to what fungal species is the type of tissue reaction. Now, what do we mean by type of host tissue reaction? It is whether the fungus is being able to mount an inflammatory response or not, and that is not guided by the immune status of the patient, and what kind of inflammation we see. At the site level, the organ level gives us also another idea. Say, for example, if it's superficial mycosis, we know it will be only involving the skin, the hair, and the nail. In an immunocompetent individual, we can see subcutaneous infections like sporotrichosis, we can see entomophthalmos mycosis as well. Now, recently, because of the COVID-19 pandemic, as already mentioned by Sagar sir, we have seen a lot of mucormycosis, and most of them were rhino-orbitocerebral involvement. Even aspergillus causes rhino-orbitocerebral involvement. So, based on the organ involved, we also get a clue as to what the fungal pathogen can be. Now, as a pathologist, in fact, in the pathology specimen itself, we can give the idea whether the fungus is invasive or non-invasive. Now, why that is important? Because an invasive fungal pathogen is invariably going to have a poorer prognosis than anything which is non-invasive, and that will guide the treatment. When we come to fungal morphology, it is a very clear-cut approach to find out whether we are seeing yeast or yeast-like forms or whether we are seeing filamentous molds. So when we talk about host tissue reaction to fungal infection, one has to remember that tissue reactions during inflammation are not diagnostic, but they can suggest the general category of fungal infection. So what are the major tissue reactions to fungal infection? I'll start with the fact that sometimes there will be no inflammation or minimal inflammation. followed by, you can see if it is a recent onset of a certain species, you will see an acute inflammation. In acute inflammation, it's mostly the polymorphonuclear leukocytes which come in. And when there is a collection of neutrophils which are viable or dead or degenerate, then that is what we call suppuration. So suppurative inflammations can be seen. Chronic inflammation with mononuclear cells like lymphocytes and plasma cells can be seen. Granulomatous inflammation, where the hallmark is formation of granulomas, that can be seen, and that is possibly the most consistent tissue reaction for invasive fungal infections. And in granulomatous inflammation, we see a variety of granulomas, from necrotizing granulomas, non-necrotizing granulomas, suppurative granulomas. So I'll take them up all according to the course of the lecture. There are other features apart from inflammation, certain other reactions that give us an idea as to what the fungal pathogen could be. Of that, very important is to note whether there is evidence of angioinvasion, that is invasion of the blood vessels in the tissue sample, whether there is infarction, necrosis, thrombosis, and hemorrhage. Certain fungi induce a specific characteristic reaction, and that's known as splendor phenomenon. I will elaborate on that. Based on the organ, say for example, if we are dealing with skin or mucocutaneous organs, we can see specific reactions like pseudoepitheliomatous hyperplasia. Now, a little bit of very basics. This is just because I know we are dealing with a heterogeneous group of participants here. So here, with the arrow A, what is shown or depicted are polymorphonuclear leukocytes, that is neutrophils, which have multiple lobes, usually 4 to 5 lobes. So you can identify them on the tissue specimen looking at their lobes. Whereas the chronic inflammatory cells, that is the mononuclear inflammatory cells, are mostly lymphocytes, which have a round nucleus. So moving on to a higher power, you can see the lymphocyte, very similar to what I showed you in this image. Then you can see a plasma cell, which is also an indicator of chronic inflammation. Then there's this large cell with an elongated pale chromatin, the pale staining chromatin of nucleus. So this is a macrophage or histiocyte. This is a eosinophil with bright eosinophilic granules. So eosinophils are also very common in fungal infections. Now, if you look at this picture, this is a very common picture that we'll see in biopsy specimens due to certain fungi. So you can see a collection of neutrophils. You can see they have multiple lobes. Many of them are degenerating. So when you get, it's kind of pus. When you see kind of pus, liquid pus in form of tissue in the tissue, that's what we call suppuration. So this is suppurative inflammation. Now, if you look at this picture, these cells are very similar to this cell. So this was a macrophage or a histiocyte. So here we see a collection of histiocytes sprinkled with some lymphocytes. So this is a classic granuloma. A granuloma is a collection of histiocytes. In granulomatous inflammation, you'll also observe characteristic giant cells, which are known as Langhans type of giant cells. So mind you, Langhans type of giant cells will not be only specific for tuberculosis. You can also see it in fungal infections. So you can see arrangement of the nuclei and a fungal spore engulfed in the cytoplasm. And this is a low power view of granulomas with histiocytes and giant cells. So we will be utilizing this basic knowledge in the next subsequent slides. Now, what about fungal morphology? Pathologist's role is quite simple. We will first try to go in an algorithmic approach. We will first see whether we are seeing yeast or yeast-like structures, or are we seeing filamentous hyphal forms. If they are yeast or yeast-like structures, we will see what is the kind of budding, that is the asexual reproduction taking place. Is it broad-based or narrow-based? We will check whether there are pseudo-hyphal structures or true hyphal structures with the yeast forms. When it comes to hyphal forms, we will see whether these hyphae are non-pigmented, that is hyaline, or are they pigmented, that is dimicaceous. Then we will see what is the septations like. Are they septate, are they posiseptate, or are they aseptate? So based on the morphological characteristics of common medically important fungi and the host tissue reaction they induce, I'll come up with the next few slides. So yeast and yeast-like structures, size is important, and budding. That helps you to identify. These pictures were also showed by Dr. Aarti, and their note source is from Laren's Mycology. It's a very useful book, and I would suggest all of the participants here can go through that book. So in this picture, what we see is blastomyces dermatitis. This is a yeast form, but what you can understand or appreciate is that it's showing a broad-based budding, and the yeast size is also quite big. Now, if you compare this with Cryptococcus neoformans, there is variability of the yeast size and there is narrow-based budding. Now, another feature which is common with some yeasts is the presence of pseudohyphae or even true hyphae. So, if we come to Candida, we have these budding yeast forms which form a string, and because of this string-like alignment of the budding yeasts, we get something which resembles a hyphae, and that's why it's called a pseudohyphae, because there are no true septations. What you're seeing is only the constrictions at the site of the budding. But of course, there are true hyphae as well, where you can see this at regular intervals, septations too. Now, another important factor to note is whether these yeasts are intracellular or extracellular. Now, when we mean cellular, which cell is it? It is the macrophage or the histiocyte. So, are the histiocytes engulfing these yeast forms as we see in Histoplasma capsulatum, or are they all extracellular as we see in Candida? A capsule is also very important because certain species like Cryptococcus, they have a mucopolysaccharide capsule, and detecting that can give you a clue as to what the fungal species is. Coccidioides immitis, they have spherules with multiple endospores. So let's look at Candida species because this is quite common, the skin and mucocutaneous infections. So this is a periodic acid Schiff stain or PAS stain in short. It's a special fungal stain which has been used. And this was a case where we saw budding yeast forms. So you can see it's a string, it's aligned like a string, and this is what we call pseudohyphae. But you can also often see true hyphae with septations. This Candida species usually induces a suppurative tissue reaction. That is, you will see a lot of neutrophils. Now, there will be morphological mimickers for Candida. It's not always a cakewalk. There are other yeast forms which can cause diagnostic dilemma. What are those? Histoplasma. With which Candida species? With Candida glabrata. And why is that? Because Candida glabrata is a species which will show only yeast forms, and it doesn't usually show any filamentous forms or pseudohyphae. So in that case, we can confuse it with fungal pathogens which have only yeast forms. Now, because of the hyphae and the pseudohyphae, we can also confuse it with Aspergillus. So there are several entities. Let us now just see this common one which can mimic Candida, but it is quite different from Candida also. So we have diagnostic pointers for that. So this is a skin biopsy where we saw in the dermis numerous macrophages. And if you look at these macrophages, they are all chock-a-block full of small, round, oval yeast cells. And they have a halo around them like a pseudocapsule. So these 3 points are very important. The moment we see this, we think about histoplasma. If we have a doubt, we look at the reaction that they're producing. Now I'll just show you the GMS staining. So this is the Gomery methylamine stain of histoplasma. So you are seeing only yeast forms. There are no hyphal or pseudohyphal structures in the background. The next thing that we see is what is the host tissue reaction. Is it neutrophilic, suppurative? No. What we're seeing here is a giant cell, which is Langhans type. So as I told you, that Langhans type of giant cells can be seen in granulomatous inflammation. So it usually induces a pure granulomatous tissue reaction. Now, having said that, there again are problems sometimes that we face with Histoplasma capsulatum. And that is, in the wake of so many AIDS cases, we very often see Penicillium marnefi. Now, Penicillium marnefi can mimic Histoplasma capsulatum. I'll tell you how we differentiate that from Histoplasma capsulatum. But there are other yeast-like species like Sporothrix and Cryptococcus, which can also cause diagnostic dilemma. And even protozoans like Leishmania or Trypanosoma cruzi can cause diagnostic dilemma. So for Penicillium marnefi, how do we differentiate? So Penicillium marnefi doesn't asexual reproduction is not by budding. What happens here is division by fission. So we see a transverse septum, and also occasional hyphal forms can be seen. For sporotrichosis, these are common cutaneous infections, and if you have a linear sporotrichoid nodular lesion and your dermatologist has given you a skin biopsy with a diagnosis of sporotrichosis, usually it will be that. But from a pathologist's perspective, it is very difficult to find these oval or cigar-shaped yeast-like cells in the biopsy specimen. But what we usually find on taking multiple deeper sections are asteroid bodies. These are very characteristic of sporotrichosis, where you see a fringe of eosinophilic material around the yeast. And the host tissue reaction can be mixed. It will be suppurative as well as granulomatous reaction. So it is not only morphology, but also the clinical presentation and the host tissue reaction. So a triad of clinical knowledge, morphology, and host tissue reaction helps the pathologist to render a proper diagnosis. Cryptococcus neoformans. Now, if you look at this histopathology slide, this has been stained with Gomery methanomen stain. The first thing that strikes the eye is the variability in the size. You have a very small yeast form here and a pretty large one there, but you see narrow budding, and then there is a hint of a capsular structure. So when a special stain like mucicarmin, which can highlight mucopolysaccharide, is done, then you can see the mucopolysaccharide positive, mucicarmin positive capsule of the yeast forms. Now, what would be the host tissue reaction? Often they infect the cerebral nervous system, but also in skin we can see cases, and there, because of this mucopolysaccharide capsule, they usually produce mucoid cystic lesions with a soap bubble appearance. Blastomyces dermatitis is not common in this part of the world. I have not seen a case so far, but it is good to know what is an example of a broad-based budding. So here you can see these yeast forms which have a thick wall, and there's almost like a collarette from where you can see a budding. The cells, the yeast cells, are also quite big. They're 10 to 15 microns, and they produce suppurative and or granulomatous reaction. Now, two words on other structures. These are fungal structures which look like yeasts. Rhinosporidium seaberry is actually now considered a protista, but it has these small sporangium and sporangiospores which come out, and they're more common in the nasal mucosa, and they evoke a granulomatous reaction. Pneumocystis girovici, that has spherical structures with a foamy background. They usually occur in clusters, and we can see sometimes a granulomatous inflammation when they infect the lungs. So coming to hyphae or the filamentous molds. So the algorithmic approach for hyphae will be first to check whether we are seeing colorless or pigmented hyphae. If they are colorless, then we call them hyaline. Now, in the hyaline hyphae, we will see what other kind of septation that these fungus have. So let's look at this picture on the right-hand corner. One can see that there is regular septations. There is dichotomous acute angle branching. Now, what do we mean by dichotomous? By dichotomous, we mean that the branching hyphae are of the same width as the originating parent hyphae. So there is dichotomous acute angle branching, regular septations. The hyphae are almost parallelly arranged to each other, and if you notice, the branching is happening in one direction, in a radial growth pattern. So when you see all these features, it is almost consistent with a diagnosis of Aspergillus species. Now look at this one. Here you have the same kind of thin-walled, regular septated fungal hyphae, but here the fungal branching is very haphazard. You don't see the radial pattern. So then, but this is also hyaline. So that is why we have a group called hyalohyophomycetes, where Aspergillus is excluded. Even Candida can sometimes cause confusion because of its true septate hyphae. So those are excluded. So for hylohyphomycetes, we have to see whether there's branching both at 45 and 90 degrees, whether it's irregular, haphazardly arranged. Then there are the dermatophytes. These dermatophytes are also hyaline septate fungal hyphae, and they reproduce by arthroconidia. So that is also very typical. So that can be appreciated on the histopathology specimen. Now, one of the major fungal organisms that we have been seeing, and we do see often, is the cenocytic hyphae, where you can see the walls are irregular and twisted. They certainly do not have dichotomous branching because this branch is quite thin compared to the parent one, and there are absolute absence of septations. So then you have to think of mucorales. For entomophthoralis, you can have more pleomorphic, wide, thin-walled hyphae and spores. And then you have the dimicaceous or pigmented fungal hyphae, where you can have olive-colored to brown-colored oval spherical structures as well as septate hyphae. Now let us come to the hyaline fungal hyphae and look at what the host tissue reaction they produce and how we come to a diagnosis. Now for dermatophytes, this is a Gomery methanomen stained picture. You can see the septate fungal hyphae and several arthroconidia. Morphological mimickers are Candida and Malassezia. Now these are yeasts. So what is the fungal host tissue reaction a dermatophyte produces? It can be very variable, but in acute lesions, it can produce a neutrophilic microabscess, and there might be spongiosis in the epidermis of the skin. So dermatophytes are mostly responsible for superficial infections in immunocompetent individuals, and we call it dermatophytosis. Now, this is a picture where on H&E stain, we can see that the epidermis is showing a lot of spongiosis, that is collection of fluid in the epidermis. The stratum corneum is very compact and hardly shows inflammatory cells, but we can pick up something like a pseudohyphae structure and some spores or spherical structures. Now, if you look at this picture, this is H&E stain, that is hematoxylin eosin stain, which is the first basic stain that any tissue is stained in the histopathology lab with. So on the left-hand side, this is again a skin biopsy where in the stratum corneum, we saw budding yeast forms as well as filamentous forms, and they're kind of standing out. On the right side, we see thin basophilic filamentous structures and numerous round yeast forms. So, crux of the matter is that Malassezia species and Candida species both appear basophilic and are clearly seen on hematoxylin eosin stain frequently. Whereas for a dermatophyte, you might often miss that on a hematoxylin eosin stain. So if you look at this kind of a tissue reaction, definitely you have to ask for special stains like GMS or PAS, right? So superficial mycosis in an immunocompetent individual may not elicit any inflammation. So this was a skin biopsy from a case of pityriasis versicolor, where we can see a very normal basket weave pattern of the stratum corneum. This is the epidermis and this is the dermis, and we can hardly see any inflammatory cells. So when you zoom in, you can see a typical spaghetti and meatball appearance with budding yeast and filamentous form that are seen in Malassezia furfur. Now, we will move on to Aspergillus because this is one of the most common hyaline fungi we see. I've already described them on the pictorial diagram. So, what are the disease entities? Allergic bronchopulmonary aspergillosis, fungal gall, systemic and invasive aspergillosis. Morphological mimickers are all the hylohyphomycosis, but sometimes Candida and Mucorales can also create confusion. So one very practical tip is to identify fruiting bodies. Now, Aspergillus will produce fruiting bodies only when they're exposed to air. So if you have a fungal ball in a lung cavity or a paranasal sinus, a specimen is coming from there, because it's more irritated, the pathologist may pick up conidiophores with the sterigmata and the conidia and can give a confident diagnosis that this might belong to hyaline fungi, that is Aspergillus species. Hylohyphomycetes, that is the hyaline fungi other than Aspergillus, can produce fruiting bodies in deep-seated non-irritated lesions. So if you see a fruiting body from a non-irritated lesion, then certainly you will not think of Aspergillus species. So this is from our collection, where a cursory glance will make you think that you're looking at a lot of yeast forms because you're seeing a lot of spherical structures. But if you look carefully, there is this fruiting body with the conidiophore and the sterigmata and conidia. So this was a case from fungal wall from my personal collection. So this is also a zooming structure of the fruiting bodies, and the same on a Gomery methanomin stain. So this was also another case where there was a fungal ball, but can you all pick up that there is a little bit of pigmented spores and a pigmented fruiting body? So having said that Aspergillus is a hyaline fungi, certain species like Aspergillus niger can produce pigmented colonies, and we can see this pigmentation. So a pathologist can think about a Aspergillus niger species also on the biopsy specimen, but that definitely needs a culture confirmation and correlation. Now, a fungal ball, it will usually, if it is not very chronic, may not induce inflammation, or if it is a chronic one, it can induce fibrosis and chronic inflammation. So this was a fungal ball caused by dense conglomerate of fungal hyphae in the nasal cavity. In allergic fungal sinusitis, which is caused by Aspergillus species as well as Nematodius fungi, you see allergic mucin, which is characterized by layered eosinophilic mucin alternating with layers of degenerated eosinophils. So this is a non-invasive form. So mind you, as a pathologist, it's our role to say whether the tissue is getting invaded by fungus. So usually if we do not see any invasion and we see this kind of allergic mucin, we do a Gomery methanomin stain, and if we pick up scanty fragmented hyphae, we can very confidently render a diagnosis of allergic fungal sinusitis. Now, Aspergillus in immunocompromised setting can cause invasion. And what are the four features? It will cause angioinvasion, that is invasion of the blood, where you can see filamentous fungal forms. And there will be thrombosis because there will be RBC and fibrin, which will be blocking these blood vessels. Because of the ischemia caused by the angioinvasion and thrombosis, there will be necrosis, and there will also be spillage of RBCs in the tissue, which is known as hemorrhage. Now, necrotizing granulomas. Necrotizing granuloma is like almost a pathologist or even a clinician will consider synonymous with tuberculosis. But the caution or caveat is that when you see necrosis, do definitely get a special stain for fungus like GMS or PAS. Here in the H&E itself, we can actually see a fungal hyphal element, and there were multinucleate giant cells as well. But this will be definitely a case where you have to run a special stain for fungal elements. Chronic invasive granulomatous fungal sinusitis is commonly caused by the species Aspergillus flavus in immunocompetent individuals. There also you can see granulomas, but along with that you see something called fibrosis. So all these pink collagenous bands that you're seeing, these are fibrosis. So you can see granulomatous inflammation along with fibrosis. There is no necrosis, no angioinvasion. So if it is quite endemic in certain parts of the world like Sudan, Africa, and also in India. And one can do a special stain like a PAS where you can demonstrate this fungal hyphal structures within the multinucleate giant cells, and with the proper triad, as I said, clinical presentation, fungal morphology, and host tissue reaction, a diagnosis of chronic invasive granulomatous fungal sinusitis can be rendered. Now, hylohyphomycetes. Here we see slender filamentous fungal hyphae. There is dichotomous branching. You get a GMS stain done and you can see a lot of these fungal hyphae. But what is missing here is the radial pattern that we were talking about. The fungal hyphae are not arranged parallelly. So in this case, the pathologist definitely has to think about alternates apart from Aspergillus. So it is very important that in a histopathology report, we do need to mention that we are seeing hyaline septate branched fungal hyphae, but you should not straight away render something like consistent with aspergillosis, because hyalohyphomycetes are very close morphological mimicker, and in certain situations, if you do not get an intact specimen, if you get a liquid specimen, you do not get to see the radial growth pattern. So in that case, you would not really be able to say whether it's Aspergillus species or whether it is Fusarium species or Scerosporium. So an alternate testing can be done, because Fusarium can give a high yield on blood culture, but Aspergillus will not. So this was a case which was in the lab diagnosed as Acromonium species. Now coming to mucormycetes. So these are also hyaline fungi, very, very important right now in the COVID pandemic situation. These, if you look at this H&E stained section, the fungal hyphae are like they're popping out. You can see very twisted, irregular fungal hyphae. There is hardly any septation, just one or two here, and there's no dichotomous branching. A little bit of budding is out here. There's some branching here. But this is an H&E stain. So what I want to emphasize is that for the Mucoralis, order Mucoralis, these are well visualized on the H&E stain. And what are the disease entities that they cause? Rhinocerebral, pulmonary, and cutaneous infections. But morphological mimickers can be any other non-pigmented molds. Even the hyaline fungi of Aspergillus or non-Aspergillus species can also mimic it. Now, this is a pass stain for the same case. Not much extra information. What we were seeing on the H&E, it's almost the same. In fact, the H&E was better. But on the GMS stain, we see them brightly enhanced, standing out in a background of light green dye. But one thing is noticeable here is that Gomery methylamine silver stain is a stain where fungi usually pick up a black intense color. But here the color is brown. So this is something which one needs to remember. What is the host tissue pattern that they produce? So Mucoralis in acute fulminant mucormycosis can produce bland infarction. Now, when we say bland infarction or necrosis, we mean that we are not seeing inflammatory cells. This is infarcted tissue, but there is hardly inflammatory cells, but you can see the twisted, folded hyphae of Mucoralis. Now, just 1 minute. Yeah. So, angioinvasion is a typical feature of Mucoralis. So we can see a vessel wall being invaded, and this is a lot of fungi within the blood vessel lumen causing thrombosis. Now, we saw a spectrum of bland infarction with hardly any inflammation in acute fulminant mucormycosis. But when there is a chronicity, we can see dense inflammation with suppurative granulomas. Now, when you see this kind of granuloma with a giant cell, let's zoom in. So you can see central neutrophils, palisaded histiocytes. And for the trained eye, one can pick up this fungal hyphae. But what if you have not? So in these suppurative granulomas, it's mandatory to get the GMS and pass special stains for fungus. So you zoom in and you can see this fungal hyphae. Now, because it's Mucoralis, it's standing out on the H&E stain. You can see all these irregular, twisted, non-septate fungal hyphae, and you can possibly confidently give a diagnosis of mucormycosis. But if it had been Aspergillus, it would not have been that easy, or if the fungal load had been lesser, it would not have been easy. So in that case, to get a pass stain. And also a GMS stain, so that highlights the fungal hyphae. Now, bone invasion is also caused by mucormycosis as well as aspergillosis and can lead to fungal osteomyelitis. So this is lamellar bone, and the intertrabecular spaces show fungal hyphae. So this is just a reiteration of whatever I've said so far. Left side is aspergillus, right side is mucoralis, and the difference is clearly visible. Now, this was one case from our personal files.
One moment.
This was one case from our personal files.
Working on that. I didn't get that. Could you try again?
Just bear with me. Yeah. So here on the right hand side on a Gomery methylamine stain silver stain, we can see dichotomously branching filamentous fungal hyphae which are intensely staining with JMS. They look black. But if you look on the left hand side, these are irregular broad fungal hyphae which look quite brown. So the staining pattern is different. So if there is a confusion between Aspergillus or Mucorales, looking at the GMS staining pattern, one can give a presumptive diagnosis. Now, entomophthalomycetes are also pauciseptate fungal hyphae, which have less branching than Mucorales. They occur in immunocompetent individuals and cause subcutaneous infection. The clinical pictures have been shown by Dr. Dinesh Asati. Now, he had also mentioned splendor hepli phenomenon. So this is what you see on the biopsy specimen. Splendor hepli phenomenon is this eosinophilic eosinophilic material on the fringes of the fungal hyphae caused by antigen immunoglobulin reaction to the fungal antigen. Now, splendor hepli phenomenon, this is a picture from a nasal biopsy where you can see all these pink material. You zoom in, you can see something like a broad fungal hyphae. Further zooming in, you can see this eosinophilic material, and you can also see eosinophils, which is sometimes characteristic of a fungal infection. Coming to Dimetaceous fungi, they contain melanin, which is very typical, and we can pick that up with special stains like Mason's fontana. The common disease entities are chromoblastomycosis, phaeohyphomycosis, mycetoma, but they can cause other diseases as well. Now, in chromoblastomycosis, you see this typical copper benny bodies or sclerotic bodies, which are brown, pigmented, and show transverse or horizontal septations. And the tissue reaction that they induce is that of pseudoepitheliomatous hyperplasia in the skin with epidermal proliferation and intense inflammatory infiltrate. If you zoom in, you can see these are all neutrophils, that is suppuration is taking place, but also there is a Langerhans giant cell peeping there. So it is not only suppuration, but suppuration and granulomatous inflammation. And there, right in the neutrophilic or suppurative abscess, you can see the sclerotic bodies. Now, mycetoma is also caused by Dimetaceous fungi. So here you can see a mycetoma granule, and surrounding that is neutrophilic abscess. You zoom in, you can see this is a case where you can see fungal hyphae with chlamydospores and swollen cells. So this is eumycetoma, which is caused by fungi. But if you look at this one, which is also a granule, the appearance is very different. You can see a dark bluish staining on the fringe with a pale center. If you zoom in, you can see filamentous, thin thread-like filamentous fungi with a surrounding intense neutrophilic reaction. So this is actinomycetoma, where you see filamentous fungi, and that is caused by a higher order bacteria, but the presentation is quite similar. So mycetoma also induces splendor hepli phenomenon. So you can see this pink material around the fringes of the granule. And other organisms that produce splendor hepli phenomenon are Coccidioides and Sporotrace schenki. Few hyphomycetes are pigmented fungi, but how are they different from chromoblastomycosis? So here you can also see hypha-like forms, and yeast-like forms, you don't see sclerotic bodies. They cause deep dermal suppurative nodules. Mason's Fontana stain can help you to demonstrate melanin. Now, I had presented superficial mycosis for Malassezia furfur, where I showed there could be no or minimal inflammation in an immunocompetent individual. But in an immunocompromised individual also, we can see a setting where there is no inflammation. So this is from one of the personal case files where a post-renal transplant patient had disseminated candidiasis. So the skin biopsy showed intense subcutaneous invasion by candida. So we zoom in, and what do we see? Mind you, this is a hematoxylin eosin stain. This is not a PAS stain, this is not a GMS stain, and still the fungal elements are very clearly visualized. You can see budding, you can see fungal filamentous forms. And next to this, you can see a blood vessel where there is thrombosis and fungal hyphae within the lumen. So This was a case of disseminated candidiasis, but what is striking here is the total absence of inflammatory cells. So in a setting of immunocompromise, when the host cannot mount a attack, cannot mount an immune response, you can see florid fungal dissemination. So this is a past stain of the same biopsy specimen where you can see the typical morphology of Candida. Now, dual infection, identifying dual infection is also important because it has important treatment and prognostic implications. The other thing is that the laboratory may grow something on the culture and the pathologist is not seeing that, or the pathologist is seeing something that's not grown on the culture. So we have to keep in mind that sometimes on the biopsy specimen, we might be able to pick up many pathogens which are non-viable. So they may not grow on the culture, but we will be able to see. So this is also from a personal case file where we saw budding yeast forms of Candida along with this broad aseptate fungal hyphal forms of mucormycetes. This is a case where there was aspergillus like, it's wrong to say aspergillus because it's hyaline fungi. So there was dichotomous branching, there was filamentous septate forms, along with this broad pauciseptate fungal hyphae. So you do a PAS stain and you do a GMS stain and you check for all the features that I have already mentioned. These are the things that we do to find out whether we are seeing dual infection. And this is the same which I've already shown. So, in conclusion, a histopathology report must include the following. It should include the morphological description of the fungus. That is, are we seeing yeast forms or are we seeing hyphal forms? If we are seeing hyphal forms, are they pigmented or hyaline? Are they septate, pauciseptate, or aseptate? After that, there should be a comment on the presence or absence of tissue invasion and what type of host reaction they are producing. If it is tissue invasion, for example, if I exemplify by this, I'll take the example of mucormycosis. Mucormycosis can be invasive, but in acute fulminant mucormycosis, the tissue reaction will be that of acute inflammation. Whereas if it becomes chronic, for example, in case of Aspergillus flavus induced chronic invasive granulomatous infection, you will see tissue invasion, but there the host reaction is granulomatous. So that has important implications for classifying the kind of infection that one is seeing, and the clinician can post his treatment accordingly. And also at the end, there should be a comment stating the most frequent fungi associated with the said morphology, as well as other possible fungi or parasites that should be considered in the differential diagnosis. So for histoplasma, as I told in the previous slides, that parasites also do come in the differential diagnosis. So take home messages. Histopathology is a rapid and cost-effective means of providing a presumptive or definitive diagnosis of fungal infection. Morphological characterization of fungal pathogen is important to guide treatment, and the host tissue reaction, which is induced by fungal elements, tells whether the fungus is a colonizer or a contaminant or a true infection. So that's all from my side. Thank you, and I'll be happy to take any questions.